Imagine a gold standard medical society, officially telling doctors to give women a drug that's, well, specifically designed for men, simply because pharmaceutical companies didn't find the female version profitable enough to keep on the shelves.
I mean, it sounds like a conspiracy theory, honestly. But it is the very real and very frustrating reality of modern medicine.
Welcome to today's deep dive. We are tackling a subject that is incredibly complex, deeply personal, and frankly entirely saturated with conflicting information.
Oh, absolutely. The diagnostic landscape is incredibly murky right now.
Right. If you, or maybe someone you know, is navigating the physical changes of aging, from sudden brain fog to painful shifts in physical intimacy, you know exactly how overwhelming the medical advice can be.
Yeah, it's a lot to sift through.
So our mission today is to cut through that murk. We're going to separate the established gold standard medical guidelines from the absolute wild west of emerging regenerative treatments. We're looking at what happens when rigorous clinical evidence collides head-on with, aggressive wellness marketing.
And to do that, we are drawing from a really compelling stack of research today. We're analyzing the newly updated May 2026 British Menopause Society practice standards, pulling data from a 2026 meta-analysis in Frontiers in Medicine.
Which is a fantastic study, by the way.
It really is. Plus, we're breaking down a 2024 clinical trial evaluation out of Oklahoma State University and comparing all of that hard science against the glossy marketing materials being pushed by private wellness clinics.
Okay, let's unpack this, because before we can even begin to understand the bleeding edge, futuristic treatments being heavily marketed to women, we have to start at the baseline.
Right, the foundation.
Exactly. How does the medical establishment currently define and treat the everyday changes of aging? Let's look at the new British Menopause Society, or BMS, standards, because they have completely reframed how we even get a diagnosis.
They absolutely have. And it's a massive paradigm shift for anyone used to the old way of doing things. I mean, historically, doctors relied heavily on a lab readout.
Right, like getting your blood drawn.
Yeah. They would draw your blood and look at your follicle-stimulating hormone and estradiol levels to determine if you were in menopause. But the May 2026 standard throws that out the window for the vast majority of women.
Wait, really?
Yeah. Now, for women over 45, the diagnosis of perimenopause or menopause should be based on symptoms alone.
Okay, so if I go to the doctor feeling like I'm losing my mind, dealing with hot flashes and exhaustion, they don't even check my hormone levels to confirm it. They just take my word for it.
Unless there's a very specific diagnostic uncertainty, no. No blood tests are needed. And there is a brilliant physiological reason for this.
Which is?
During this transition period, your hormones are fluctuating so wildly that a single blood test is essentially just a snapshot of a roller coaster.
Oh, I see. It's like a mechanic telling you that you don't need to plug the car into a computer to read the error codes. If the engine is sputtering and there's smoke coming out the back, you just, trust what the car is physically showing you and fix the engine.
That's a perfect analogy. The labs don't tell the whole story. So if you get your blood drawn on a Tuesday when the roller coaster's at the top of the track, the doctor might say, well, you're fine, your estrogen is high.
But by Thursday, I'm at the bottom of the drop and completely miserable.
Exactly. So the guidelines now dictate that doctors must trust what the body is physically experiencing.
That is surprisingly validating, to just be trusted on the symptoms. And the symptom list in these guidelines is vast. I mean, the average age of menopause in the UK is 51, with the normal window starting around 45 to 55.
Yeah, and more than 75% of women experience symptoms. A third of them experience long-term symptoms.
And we aren't just talking about the stereotypical hot flushes. The BMS highlights cognitive symptoms, so severe brain fog, a sudden, inexplicable loss of confidence.
And crucially, genitourinary symptoms.
Right.
This includes vaginal dryness, incredibly painful intercourse, and recurrent urinary tract infections. What's insidious about these specific symptoms is that they often present years after menopause officially begins.
Long after a woman thinks she is through the worst of the transition.
Exactly. Which brings us to the first-line defense, which is HRT, hormone replacement therapy.
The guidelines still point to this as the most effective treatment. But what really stood out to me in the new standards is the focus on how that hormone is delivered, especially for women who might have a higher risk of blood clots, or those with a raised BMI.
Yes, the delivery mechanism changes the safety profile entirely. For those women, the guidelines strongly recommend transdermal estradiol.
So a patch.
Right, delivering the estrogen through the skin via a patch or a gel rather than swallowing a pill.
But why does the delivery method matter so much? I mean, if the estrogen's getting into the bloodstream anyway, why is a patch rubbed on your arm perfectly safe, but a pill you swallow might increase the risk of thrombosis?
It all comes down to the liver.
The lip.
Yeah. When you swallow an estrogen pill, it has to be processed by your digestive system and then metabolized by your liver before it reaches the rest of your body. That process in the liver actually triggers the production of specific clotting proteins.
Oh, wow.
But when you use a patch or a gel, the estrogen is absorbed directly through the skin into the bloodstream. It bypasses that initial liver metabolism entirely.
Meaning those clotting proteins are never triggered. That makes perfect sense. So you get the systemic benefits without the dangerous liver trigger.
Exactly.
The standards also mention that for the localized issues, like the vaginal dryness or painful intercourse we mentioned, women can use low-dose vaginal estrogen long-term.
Yes, and they can do this without needing a systemic progestogen to protect the uterus because the localized absorption is so incredibly low.
That is a huge relief for many patients who just want to treat local discomfort without altering their entire systemic hormone profile. But if you're listening to this and wondering, is there ever a time they still use blood tests? The answer is yes, but only in a very specific scenario.
Right. If a woman is under 40 and experiencing these symptoms, the medical community considers that premature ovarian insufficiency, or POI.
At that point, because it's happening outside the normal biological timeline, doctors do need objective data.
Precisely. That's when they look for elevated FSH levels, usually above 25 on 2 separate occasions, to rule out other potential pathologies. The biological context dictates the diagnostic tool.
Okay, so HRT is fantastic for managing the hot flashes, the brain fog, the baseline structural changes. But here is the massive gap in standard care. What happens when a woman gets her estrogen balanced, the pain is gone, but her sexual desire is just entirely missing?
This is where standard medicine hits a very uncomfortable commercial wall. The British Menopause Society is remarkably clear on this. If HRT with adequate estrogen isn't effective for low sexual desire, doctors should consider testosterone supplementation.
Which makes sense physiologically. I mean, women produce testosterone just in smaller amounts than men. But when I looked for the recommended female testosterone product in the UK, I couldn't find one.
Because there isn't one. There are absolutely no licensed testosterone products for female use in the UK right now.
But they used to exist, right? What happened to them? Did they discover some massive safety flaw?
Not at all. There were female patches and implants available previously, but the licenses were withdrawn entirely for commercial reasons.
Wait, commercial reasons?
Yeah, the pharmaceutical companies simply didn't find the female formulation profitable enough to maintain production. The BMS guidelines state this explicitly.
So what does this all mean? We have a gold standard medical society officially telling doctors to use a drug off-label for women simply because pharmaceutical companies didn't find the female version profitable enough to keep on the market. That is wild.
It is wild. So it has become common, accepted medical practice to prescribe male-licensed testosterone off-label.
Like using the men's gel.
Exactly. Doctors take the gels designed for men and instruct their female patients to use a very tiny, meticulously measured fraction of the dose to mimic female physiological levels.
And I imagine this is where blood tests do come back into play for older women, right? Just to make sure they aren't accidentally pushing their levels too high with a male drug?
Yes, exactly. You aren't using the blood test to diagnose the low desire. You are using it to establish a safety baseline.
To make sure their natural testosterone isn't already surprisingly high.
Right. And you want to monitor the off-label use to prevent superphysiological replacement, which is just a fancy way of saying you don't want to accidentally give a woman male-level hormones, which could cause unwanted side effects.
Things like hair growth or vocal changes.
Exactly.
So think about the position this puts a patient in. Standard medicine acknowledges her problem, but the commercial reality forces her to essentially microdose a medication designed for a man.
It's incredibly frustrating.
It is. That kind of friction, that gap in dedicated care, creates a massive vacuum. And whenever there's a vacuum in medicine, private wellness clinics are going to rush in to fill it with novel, highly marketed alternatives.
And that transition is exactly what brings us to the regenerative medicine frontier. What's fascinating here is that if standard hormonal treatments feel clunky, or if they simply aren't fixing the anatomical thinning or the loss of physical sensitivity, these private clinics are offering a completely different approach.
Right. They are pitching a procedure that utilizes the patient's own blood.
Yes, platelet-rich plasma therapy. or PRP.
Often marketed in this specific context as the O shot. Now, when I first read through these glossy clinic brochures, they make it sound like absolute magic. But let's strip away the marketing. What are they actually doing to the blood?
The mechanics are actually quite elegant. A clinician draws a small amount of the patient's blood and places it into a centrifuge.
Okay.
This machine spins the blood at an incredibly high speed. That rapid centrifugal force separates the heavier red and white blood cells from the lighter liquid plasma and the platelets.
So you're isolating the platelets. And because this is autologous, meaning it comes entirely from your own body, the risk of having a severe allergic reaction or your body rejecting it drops to virtually zero, right?
That's a major selling point, yes. But the real value is in what those concentrated platelets contain. They are packed with specific growth factors.
Like what?
Well, vascular endothelial growth factor, platelet-derived growth factor. The names are complex, but their function is simple.
Yeah.
When you inject these highly concentrated growth factors into a localized area of the body, they act like biological signal flares.
Oh, signal flares.
Yeah, they essentially trick the body into initiating a massive, accelerated healing response in that specific location.
So wait, if you're pulling out these highly concentrated growth factors and injecting them into tissue that has thinned out or lost its vascular health due to aging, is it basically like creating a hyperconcentrated biofertilizer out of your own blood and applying it exactly where the soil has gone dry?
That is an incredibly accurate analogy. You are providing the exact biological building blocks needed to regenerate the soil. It stimulates the production of new collagen, it triggers tissue repair, and crucially, it initiates neovasculogenesis.
Which is the creation of new blood vessels.
Brand new, healthy blood vessels from scratch.
And more blood vessels mean more blood flow, which in theory means heightened sensitivity. Now, the application of this for women's sexual health was pioneered by a physician named Dr. Charles Runels.
Yes.
According to the historical notes in our sources, he originally developed the procedure by injecting this plasma into his girlfriend's clitoral region and anterior vaginal wall.
That's right. And the clinical procedure today is virtually identical to that origin. Because that area of the anatomy is profoundly sensitive, clinics use a highly potent, specialized numbing cream.
Called BLT, right? Benzocaine, lidocaine, tetracaine.
Exactly. And once the tissue is completely numb, they take about 5 cc's, so roughly a single teaspoon, of the spun plasma and inject it directly into those targeted zones.
The marketing claims from the clinics we looked at, places like Optimal Medical Group and Dr. Michael Goodman's clinic, they are not subtle. They promise increased natural lubrication, massively enhanced orgasms, a spike in sexual desire, and even relief from chronic, painful skin conditions like lichen sclerosis.
And if you look strictly at the localized biology we just discussed, the mechanism makes sense. Thicker, healthier, more vascular tissue should theoretically translate to improved sexual function.
The mechanism sounds flawless. But here's where it gets really interesting. I'm always skeptical of glossy brochures making miracle claims. So the real question is, what happens when we pull this out of the private clinic and put it under the microscope of independent, rigorous research?
Do the receipts actually match the hype?
Right.
Well, to answer that, we turn to the 2024 analysis from Oklahoma State University. These researchers wanted to evaluate the hard, objective data on using platelet-rich plasma specifically for female sexual dysfunction.
Which is a massive issue. I mean, sexual dysfunction affects roughly 50% of women who seek urogynecological evaluation.
It's huge. So they go digging into the clinical trial databases. They find 18 studies registered. But right away, there's a red flag. Only a third of those trials were actually completed and published.
Yeah, the attrition rate for these studies is really high.
It is. But when they looked at the data from the studies that were completed, the findings were an absolute bombshell. Of the published results, none, not a single one, found statistically significant improvements in sexual satisfaction or arousal.
Wait, really? Zero?
Zero statistical significance compared to the baseline or control groups.
But how is that possible?
Yeah.
We just established that the biofertilizer mechanism works to build new blood vessels. So if the clinical trial shows zero statistical improvement for sexual arousal, are all these glowing clinic testimonials just an expensive placebo effect? Or is there a flaw in how we measure sexual satisfaction in these trials?
It's likely a combination of both, to be honest. And it highlights the danger of subjective endpoints in clinical trials. Sexual arousal is not a simple hydraulic equation.
Right, it's not just blood flow.
No, it is profoundly complex. Comical.
Okay, so if a woman's lack of desire is stemming from the fact that she's incredibly stressed at work, or her systemic estrogen and testosterone are completely depleted, injected growth factors into the local tissue isn't going to fix the root cause.
Exactly.
No.
You are only addressing one localized structural component of a highly complex multi-system issue. Furthermore, trying to quantify satisfaction or arousal on a standardized clinical questionnaire is notoriously difficult.
Yeah, that makes sense.
But even taking those measurement hurdles into account, the gap between what the private clinics are promising on their websites and what the independent clinical data can actually prove is stark.
It really is. Okay, so if the story ended there, we would just write the O-shot off as a highly marketed structural fix that overpromises on complex psychological results. But it doesn't end there.
No, it doesn't.
Because while the data for sexual arousal fell entirely flat, these exact same plasma injections yielded a totally unexpected side effect. And it turned out to be an incredible medical breakthrough for a completely different problem.
Yes, the clinical pivot here is fascinating. Women who were getting these injections, hoping for improved sexual function, started coming back to their doctors reporting something else entirely.
Stress urinary incontinence.
Exactly. They were saying their SUI, the frustrating reality of leaking urine whenever they coughed, laughed, sneezed, or exercised, was suddenly clearing up.
Which is a massive quality of life issue for millions of women. So researchers actually chased this lead. And this is where the data gets undeniably solid. We're looking at the March 2026 meta-analysis published in Frontiers in Medicine.
A great paper.
Yeah, they reviewed 8 different studies involving over 250 women, specifically evaluating plasma injections for stress urinary incontinence.
And unlike the subjective sexual arousal data, the data here is incredibly compelling. The plasma significantly improved symptom severity across the board. Patients reported massive drops in their standardized incontinence symptom scores at the 1-month and 3-month marks.
Scores on the UDI-6 and ICIQ-SF questionnaires. Right?
Yes, exactly. Those dropped significantly.
But what I love about this study is that they didn't just ask the patients how they felt. They didn't rely on subjective questionnaires. They hooked them up and measured the physical objective function of the bladder and urethra.
Right, the urodynamic improvement.
Yeah, they measured the abdominal leak point pressure, or ALPP. Basically, they measured the exact amount of physical pressure the body could withstand before the dam broke and leakage occurred.
And that objective pressure threshold showed a massive, statistically significant increase. I mean, the mean difference was over 50 points. That means the pelvic floor and the urethral sphincter could withstand significantly more physical stress, more coughing, more jumping before feeling.
The underlying support structure was objectively stronger. But there's a really fascinating quirk in the data here. The researchers noted that while the pressure capacity vastly improved, the actual functional profile length of the urethra didn't change at all.
Which tells us exactly how the plasma is working in this context. It implies that the growth factors are improving the quality and the functional strength of the existing tissue, likely through that intense collagen production and vascularization we discussed earlier.
Right.
It's fortifying the walls of the structure, even if it isn't altering the structural dimensions themselves.
It is exactly like taking a pill, hoping it will cure your headache, realizing it does absolutely nothing for your head, but waking up to find it miraculously fixed your bad knee.
That's spot on. And if
Right.
we connect this to the bigger picture, it forces us to completely reevaluate the regenerative therapy landscape. Platelet-rich plasma might not be the guaranteed magic bullet for libido that wellness clinics promise on their social media ads.
Definitely not.
But the rigorous data proves it is a highly effective, deeply safe, non-surgical intervention for urinary incontinence by strengthening those underlying support tissues.
And let's talk about that safety profile, because in these incontinence studies, it was excellent. There were no serious complications reported. The researchers noted only the most minor, self-limiting issues.
They call them Clavien-Dindo grade events, which basically means things like temporary spotting or very mild transient discomfort at the injection site.
Basically, the absolute lowest level of medical complication possible.
Which is the primary benefit of utilizing an autologous treatment. When you are using your own biological material, the body knows exactly what to do with it.
So if you're listening to this and trying to make sense of your own health, or maybe trying to support a loved one through these transitions, look at the journey we've just taken. You are now armed with the actual data. You know that the gold standard medical guidelines validate your symptoms, and you don't need a frustrating blood test to prove what you are physically experiencing.
You know the systemic benefits of bypassing the liver with transdermal HRT, and you understand the commercial realities forcing doctors to prescribe off-label testosterone for low desire.
And perhaps most importantly, You now know exactly what to look for and what to be skeptical of when a private clinic offers you a miracle regenerative shot. You know it might not fix a complex issue like libido, but it holds very real, scientifically proven promise for strengthening the pelvic floor against incontinence. Knowledge really is the absolute best defense against both untreated symptoms and predatory marketing.
It really is. It allows you to advocate for the care that actually works.
Absolutely. But before we wrap up today, I want to leave you with one final, slightly provocative thought to mull over. Right now, to perform these regenerative plasma treatments, clinics are drawing aging, potentially depleted blood from older patients to fix age-related pelvic decline.
Yeah, the treatment works, but your raw materials are only as vital as the current age of your body.
Right. But what if we took this underlying science just one step further? Think about the implications here. How long is it going to be until plasma banking becomes just as common as freezing your eggs?
Oh, that is an interesting concept.
Imagine a world where you go into a clinic in your 20s, extract and freeze your vibrant stem cell-rich, highly potent blood plasma, specifically so you can thaw it out decades later to use as the ultimate personalized, hyper-concentrated regenerative treatment for your own body when menopause hits.
Using the pristine cellular material of your own youth to heal and regenerate your future self. I mean, it is a fascinating and highly plausible biological concept.
It really makes you wonder. We started today talking about how the diagnostic tools in post-reproductive health are broken, leaving women in murky waters. But maybe, just maybe, treatments like platelet-rich plasma, when they are guided by hard clinical science instead of just flashy marketing hype, are the first actual steps toward finally clearing that water up.